Thanks everyone for coming out to the first lecture at InChip this semester. I want to welcome especially Dr. Sheila Shenoy. She's going to be giving a talk today, and just some background information on her. She's an assistant professor in the Yale School of Medicine and works specifically in the Yale AIDS program. Her background, she has an MPH from Tulane School of Public Health, as well as an MD from UConn Health. So she's back to visit with us after a few years. In terms of awards, she was a Fulbright Scholar, as well as receiving a Fogarty Fellowship from NIH in Global Health Research. Her focus overall is on TB and HIV integration within community-based settings. Her work, one of the great things about the work that she's doing is she is working in some of the most challenging areas to do this type of HIV, TB prevention work. The resources are almost nil, so whatever she does, she has to bring to the setting. Some of the places where she's done this work are in Liberia, Ukraine, and today she's going to focus her talk on the work she's doing in South Africa with TB and HIV screening in a community-based type of environment. We also learned that she's a great resource for grad students who want to talk to her about how to balance family and work life. So being from Yale, they don't have a reputation for letting you do that, so she's managed to do it somehow. So welcome, Sheila Shenoy.
Good afternoon, everybody. Can everybody hear me? Awesome. Thank you. So my name is Sheila Shenoy. I went to UConn for medical school in Farmington, and I did the rest of my clinical training in New Haven. Before med school, I did my MPH at Tulane, and I'm really excited to be here today talking to you about some of the work that I'm doing in South Africa. So let's talk, here we go. Okay, so hopefully this is a review, but most of you hopefully are familiar with the 90-90-90, which originated within the TB field, with the HIV field, where the goals are 90% of people living with HIV knowing their status, 90% of those people being on treatment, and 90% of those people being virally suppressed. The TB community has subsequently adopted something very similar, as you can see here. 90% of all people with TB should be reached and placed on appropriate therapy. And then 90% of those key populations reaching the focus on people being the most vulnerable, underserved, and at risk, and focusing on treatment success for those people with TB. So I just wanted to go over that as a frame for what we're going to be talking about today. I'm just going to introduce where I work in South Africa. I know there's many people in this room who are familiar with this part of the work, this part of the world, and who have done work there. So you can see there we go. So on this whole colored side is the province of KwaZulu-Natal on the eastern part of South Africa, and Tugela Ferry is a small town right in the center of KwaZulu-Natal province, or KZN, Umzinyathi district. For those of you who traveled there, you would have flown into Durban, which is here, right on the coast in eThekwini, and then driven about 3 hours inland. Okay? So this is an area of approximately 180,000 traditional Zulu people with very high HIV prevalence amongst pregnant women. About 1 in 3 pregnant women are living with HIV. Very high TB incidence, about 1,000 per 100,000. In a very poor part of the country. It's one of the poorest sub-districts in the country. It's usually in the 1, 2, or 3 poorest in the country year to year. High unemployment, low levels of electricity, low levels of piped water. We work in partnership with the district government hospital, which is a 300-bed facility, surrounded by 16 nurse-led primary care clinics. And that's the healthcare infrastructure for this whole region of 2,000 or so square kilometers. And these are just some pictures here to give you a sense of what the environment is like, that this is a very rural area. These are very traditional and common Zulu huts, plaster-based, thatched roofs, traditional dress, unpaved roads predominantly through the area. There's only one paved road, and that's the road that goes from Durban all the way to Johannesburg. Everything else is unpaved. And so getting around requires a 4x4 with high clearance. And this is an area that's not good for farming. It was an area that's particularly challenging and was purposely selected by the apartheid government to move Zulus to create a whole new homeland. It was specifically chosen because of its harsh environment at the time. But this is where we are. So for tuberculosis, the WHO has endorsed the 3 I's for improving TB amongst people living with HIV. TB being the leading cause of death for people with HIV globally. They recommended a 3-pronged approach, and that includes intensive case finding, isoniazid preventive therapy to reduce the incidence of tuberculosis, and then infection control. So, and those are the 3 I's. We know that over time, informally, the 4th I, or initiation of ART, has become a primary focus of HIV care and TB care for people living with HIV. And so it's actually the 4 I's. So what I'm going to focus on today is talking about the case-finding work that we've done in this setting. I'm not going to have time to talk, unfortunately, about TB preventive therapy, although that's a major part of what we're doing in South Africa, nor the infection control. But the crux of what we focus on is community settings. I did initially work inside the healthcare environment, in the hospital and the clinics, when I started working in South Africa. And I really came to appreciate the tremendously high morbidity and mortality for people coming into the facilities. That was preventable. We had extremely high rates of advanced disease. By the time people came in, you could offer them all the TB therapy and antiretroviral therapy for HIV that we could, but their disease was very advanced. And it seemed like we had to reverse that trend. So to me, to do that, to be able to reach people earlier in the course of disease, that required me going out into the community. Because by the time people come in, it's often too late. So a lot of my work up until this point has focused on case finding. And what is TB intensive case finding? It's looking and trying to make the diagnosis earlier in the course of disease so we can improve not only individual outcomes, but also decrease transmission and try to get ahead of the epidemic as a whole. We're actively looking for cases instead of passively waiting for patients with symptoms to come to the healthcare facility. And there's some areas of debate on how best to accomplish case finding for tuberculosis in terms of who should we be targeting. Should we be targeting people who are particularly high risk or the general population? People who are HIV infected, people who are contacts of people with tuberculosis. Which tools should we be using? Should we be using symptom screens? Should we be X-raying everybody? Should we be testing everybody, getting everyone to submit a sputum and test them? Where should we be doing this? A lot of people propose just focusing on HIV-positive patients in HIV clinics or inside healthcare facilities versus going outside. And then who's the best to do this kind of screening? Should we be relying on clinically trained staff, or can we use non-clinical personnel, such as community health workers? What I did for my K-23, or my Career Development Award, was to develop a community-based strategy integrating TB with HIV case finding. And this involved developing a team of nurses and lay people, including HIV counselors, to do TB symptom screen. And people who had a positive symptom screen, we would ask for a sputum. And then concurrently also doing rapid HIV testing. And for those who were positive, we offered them and conducted a rapid confirmatory test. And if the confirmatory test was positive, then we offered phlebotomy for CD4 count. All in the community at various types of settings. And this was done in conjunction with the Department of Health. We subsequently, over the course of this work, added in non-communicable diseases as well, the screening for glucose and blood pressure, partly to decrease the stigma associated with this screening work and offer people more of a general health checkup and make it much more attractive. So overall, over the course of this work, we screened about 14,000 people in this rural area. We're going to talk about that today. The types of settings that we were screening included taxi ranks. For those of you who work in South Africa, you know that that's a common term for basically the bus station, where different bus stations, different bus routes cross, and people might get off of one and get onto another. Home-based care events, where community health workers serving their local communities organize events in the community. For education purposes, we would come in and offer testing services in addition to that. Municipality events, which can be very large, held by the local government for a variety of reasons. And we would have our team be part of the agenda on the program. They would go up and give health education and offer testing service and say, talk about STDs or whatever it is, and then say, oh, our van is over here, please come see us if you're interested. That kind of setup. Secondary schools, more as a landmark. We weren't necessarily targeting children. The Department of Education put a moratorium on testing children in schools, even adolescents, even though the legal age of HIV consent is 12 in South Africa. They put a moratorium on testing of adolescents in school settings because they were concerned about the psychological impact of such testing. So we continued on with just people who were working at the school, adults who were working at the school, or people in the neighborhood of schools. We weren't necessarily targeting the children. And then pension pay points. And that's where people came to collect their monthly welfare stipend. Literally, there's a little tuck shop or a little convenience store and a big field. One day there's nothing there except the tuck shop. The next day, on pension day, there's an armored car or armored truck that comes out from the city. Big burly guys in suits with AK-47s, literally, and then throngs, hundreds of people will show up that day to collect their welfare stipend. And so it's a place where there's a lot of people. We could target people before they're collecting their stipend for testing. So we conducted 322 of these screenings in the community over the course of a couple of years. And our initial analysis of the first 5,600 people screened, we identified over a third of people with TB symptoms. We were able to collect a sputum from half of those people who reported symptoms. And amongst all, we identified 4% of 41 cases with microbiologically confirmed tuberculosis. And I should clarify that most cases of tuberculosis in these kinds of settings are not microbiologically confirmed. They're clinically diagnosed because of capacity, infrastructure, testing, facilities, etc. So nationally, only about 40% of TB cases in this high prevalence setting are actually microbiologically confirmed. We wanted the higher rigorous bar to make sure that we were doing things, we were detecting true cases, and so that's why we focused on that. Also, being community settings, we don't have the luxury of having X-ray or other things that would be available in clinical settings that would aid in the clinical diagnosis. So So these were all microbiology confirmed, and this is for those of you who are familiar with TB, this was pre-gene expert, so this is AFB and culture-based diagnosis. Concurrently, we're offering HIV testing at the same time. 91% of people in the community accepted HIV testing this way, literally under a tree, next to the mobile clinic, at the taxi rank or bus station. That was all done individually and confidentially with voluntary consent. We identified just about 10% of people who were living with HIV. We performed phlebotomy in 85% of people who were confirmed to have HIV. And the median CD4 count amongst those was about 382 over time. So overall, this is a breakdown of the different kinds of sites. And you can see the number of people screened in these different sites vary. And these are all this is all convenience sampling, what was happening in the community that month. We got the calendars from the different government agencies on where they were having their events. And we would develop our own calendar based on places we had been in the prior months and where we hadn't been recently. So, for example, the pension pay points happened pretty regularly on Tuesdays and Thursdays every month. The municipality events usually happened on Thursdays, so we balance out our schedule. But it's really convenience sampling. This is not by any means population-based estimates. So looking at each of these sites and the number of microbiology confirmed cases per site, you can see that the number needed to screen to find one case of microbiology confirmed TB varied tremendously. So we had everything from prisons, where we had to screen 38 people to find one case of microbiology confirmed tuberculosis, versus at secondary schools. Remember, those aren't children, those are adults in the area, where we had to screen 350 people to find one microbiology confirmed case of tuberculosis, and a range in between. So overall, though, across these 5,600 people, we had to screen 137 people to find one microbiology confirmed case of tuberculosis. And how does that compare? So here, for those of you who are familiar with screening guidelines here in the US, the number needed to screen for mammography to find one case of breast cancer is about, amongst women 50 to 59, is 350. The number of WIACs on stool specimens that we have to do to find one case of colon cancer is more than 800. And the number of chest CTs or chest CAT scans that we have to do to find one case of lung cancer is 320. And these are all clinically routine guidelines in place in the US. So community-based screening potentially is very effective in these kinds of high prevalence settings. Of these, just to go into the yield a little bit more, so we had screened 5,600 people. We confirmed, microbiology confirmed TB in 41 cases for an overall case notification rate of 730 per 100,000. Nationally, in the country, only about 400 or so per 100,000 are microbiology confirmed. So this is a lot of TB in a rural community setting that may or may not be coming to clinical attention. The national incidence was 762 at this time. Does anybody know what the US TB incidence is? Just for comparison. 2.8 per 100,000. To give you a sense of what the epidemic is like, completely at a different scale. Okay? And then the other thing I'd point out here is that we found 27% of cases of the microbiology confirmed TB were actually drug resistant. And this has, and this was spread between, it was predominantly MDR cases, but also extensively drug resistant tuberculosis, which is resistance to 4 different classes of medication. So overall, we found a substantial proportion of our cases in the community with drug-resistant tuberculosis. All of those patients we found were alive at the time that we received the sputum culture result back. And this is in stark contrast to prior data at that point that showed that most people, by the time they present to healthcare facilities with symptoms and are identified as having drug-resistant tuberculosis, 50% of people are dead by the time we get those sputum culture results back. So this was indicative that we are able to potentially find people at an earlier stage of disease and bring them into the treatment. Additionally, all of these cases but one was smear negative. And what that means is that the burden of disease was still low enough that their initial smear, which is what they do with the sputum when they bring it to the lab, they do take an initial drop, spread it out on a slide, and take a look under light microscopy and see if there's any evidence of the mycobacterium. When you have florid TB, that smear is going to be positive. And then lesser disease or earlier disease, the smear is going to be more negative. There's some nuance there to people who are infected with, co-infected with HIV, but the idea is the same, that more smear negatives indicates less burden of disease. And additionally, only one of these patients was previously treated for TB in the community. Yet 27% had drug-resistant TB. So that indicates that we potentially have primary transmission of drug-resistant TB in the community. And that flies in the face of kind of what we think about with drug-resistant TB developing as a result of acquired resistance. People who've been on treatment before, didn't finish the course for whatever reason, and then the next time they come in, they have drug-resistant TB. So this is different potential transmission, albeit with the caveat that this is all self-report, and so we weren't able to verify that people had not been previously treated. So. The other thing that it's important to note from this work is that of our 41 cases, the vast majority were HIV negative. So this is in a setting where 80% of TB in the country is HIV co-infected. And so this was a real surprise to us. Very few, 12% were HIV positive. And this is just portraying this similarly. We compared our results on the right, being community-based intensive case finding. 86% were HIV negative, 12% were HIV positive, compared to the registered TB cases in the Department of Health at that same time period, where 64% were co-infected with HIV. That was a very substantial difference. So this suggests that there is quite a bit of HIV negative tuberculosis occurring at the community level and potentially driving or perpetuating the epidemic. Because those people who are HIV negative are not necessarily coming to clinical attention getting registered as TB cases in the public sector. And there is not really a private sector in this rural area either. So this is the main avenue for clinical care. So the community epidemiology of tuberculosis seems to be very different from what we're seeing in healthcare facilities. So we worked with colleagues at the Yale School of Public Health. My colleague Jennifer Gilbert is a mathematical modeler, and we looked at what the impact of expanding this kind of strategy would be in terms of decreasing TB incidence and decreasing HIV incidence and mortality as well. So on the left, you'll see here different curves looking at a 10-year period and different levels of coverage. So what proportion of the population can we reach with community-based case finding and screening in that setting? And just to take as an example, 60%, which is this green triangle line, over 10 years, reaching 60% of the population, 1,500 cases of tuberculosis could be averted. Similarly, looking at 60% coverage from the HIV side, over 10 years, about 800 cases of HIV could potentially be averted by screening people, diagnosing people, putting them on treatment, and limiting secondary transmission. And Jennifer was also able to work with us on cost-effective analyses that I'm not showing here, but this is certainly a cost-effective mechanism for settings like this that are high TB and HIV prevalence. So overall, community-based case finding is a high-yield strategy for detecting microbiology-confirmed tuberculosis. It's an adjunctive strategy to facilitate the first 90. It's very important to utilize a variety of community settings. And I wasn't able to go into it today, but we've looked at the demographics of the people that we identified and screened at these different settings, and it's very different. We get a lot more young people at the taxi ranks. Obviously, we get a lot more older people at the pension pay points, and the like. So there's utility to looking at a variety of different settings in terms of who you're trying to reach for what purpose of screening. Unexpectedly, HIV-negative tuberculosis predominated in the community, potentially suggesting a reservoir of tuberculosis among immunocompetent community members. And this requires further exploration, but has been seen in other studies in South Africa and elsewhere. And that mathematical modeling and cost-effectiveness evaluations have suggested that there would be a tremendous impact on the epidemics if we were able to scale up this strategy. So next I wanted to talk about community-based HIV case finding, voluntary counseling and testing, as it's been historically known. And this involves extending services beyond healthcare facilities, again, to increase reach, using community events, using home-based services. The idea is to reach people where they are, because people aren't necessarily coming in. They may not perceive their own self-risk. They may not want to come into the healthcare facilities for a variety of reasons, stigma, access issues. But we want to try to, again, make the diagnosis earlier in the course of disease, when their CD4 counts are high, when they're asymptomatic, and try to get them into treatment and start antiretroviral therapy and preventive therapy for overall for TB and other conditions, so that we can improve their overall outcomes. And our goal is to refer people for HIV care, but also ideally provide resources and counseling and education for people who are test negative as well. So I can just walk you through this graph. We screened nearly 14,000 people at over almost 900 community events. HIV testing was accepted by 86% of people in this community setting. 10% were HIV positive on testing, and on confirmatory testing, we were able to perform phlebotomy for just over half of these individuals. 38% reported that this was the first time they'd ever been HIV tested. And this is also in the context of integrated TB screening, as I mentioned before. The median CD4 count was approximately 429 amongst those who we were able to get CD4 counts on. And similarly, I just want to break it down by the type of community sites. Where, and again, this is a convenience sample. We screen, for example, just under 200 at prisons and 5,500 people at municipality events. And the number needed to screen varies again. We had to screen 6 people to find 1 person living with HIV in prisons, and we had to screen 60 people to find 1 person living with HIV in schools. And the gamma in between. And this is just to break it down a little bit further. This is the number of the HIV positive individuals identified according to community site. So overall, we found the highest proportion amongst prisons, followed by health fairs and taxi ranks, and the lowest at schools. And this is breaking it down by age group and community site. So for young people, who are often the target of a lot of the campaigns and testing initiatives in this region, the 15 to 24-year-olds, we're most often identifying them at municipality events. This is the red bars, and that was pretty common. Followed by pension pay points, and then home-based care events. Whereas older individuals with HIV, besides municipality events and home-based care events, and pension pay points as well. And then by gender, because again, there's a lot of focus on women with living with HIV and identifying those people. Municipality events, followed by home-based care events, and then pension pay points, but that differed slightly in men. Pension pay points were a little bit more yielding than home-based care events. So the overall message here is that it really depends what we're trying to achieve by our screening initiatives, who we're targeting, that we should be using a variety of different settings to reach different demographic groups. Focusing on adolescent girls and young women, 15 to 24, which are an incredibly high incidence and high-risk group in sub-Saharan Africa. We've been very successful engaging this population, this demographic, through community testing. Through the community testing that I just described, looking at this subset of adolescent girls and young women, we're screened 1,800 of these young women. 93% of them agreed to test in this kind of community environment. And 93% of them are tested HIV negative. For the people who tested positive, we were able to link them and refer them to HIV care. But this is an opportunity as well to incorporate strategies for HIV prevention for a high-risk group that we're hoping to take advantage of in the future. And just to talk a little bit more about gender. So in the congregate settings, we were able to test a large number of individuals, but overwhelmingly this was women, as you can see in the orange. Only 29% were men. And similarly for people who ended up being identified as living with HIV, the majority were women, 23% were men. So overall, community-based HIV testing is feasible and is high yield. Again, as an adjunctive strategy, can be very useful. It's important to test at various community sites, and can be effective at identifying particularly high-risk groups like adolescent girls and young women. But as I'm starting to show you, we're not getting a lot of men in this with this strategy. So after this, we tried targeting households or homes to see if that would be better at identifying people, particularly men, with testing efforts. So we train lay community health workers on an integrated multi-disease screening platform. So we integrated HIV and TB screening, similar to what we've done before, and incorporated blood pressure and glucose. We trained 11 previously unemployed women from this community to perform door-to-door integrated screening. So they traveled on foot, they had a backpack with all the supplies that they needed. They had cell phones to contact the supervising nurse with any questions they encountered, and they could be in communication with each other. And they had monthly in-person reporting and pressure training as needed. So overall, we tested 1,700 people this way in this community setting. We identified almost 400 people with TB symptoms. 65% of those we were able to give a bottle to, half we were able to collect a sputum from, and we were able to get 78% of tested by GeneXpert. And for GeneXpert is a newer technology, PCR-based technology that's been rolled out in the region to improve diagnostics. That was now available in clinical settings. So our lesson from this is that community health worker-led TB screening is feasible. But as you can see, there was a lot of loss along this cascade, and that has to do with the processes involved and lessons learned that it's feasible, but we have to do better about improving this cascade using different strategies for sputum collection, getting students to the lab, and the like. Similarly, we did HIV testing in 415 households, screened about 5,000 people. 63% accepted HIV testing, and 18% tested HIV positive. And for a quarter of these people that we approached in homes, this was the first time that they'd been tested. So households, unfortunately, would not fare much better in terms of identifying men, engaging men for HIV testing, or identifying men with HIV disease. Only about 20% of the population that we tested were men, and 16% of the positive people living with HIV were men in this sample. Men overall are less likely than women to engage in HIV services across the care cascade, and they experience overall worse clinical outcomes. They're overall, if they do initiate ART, it's at a later stage of disease, and they're less likely to remain in HIV care, and they experience higher mortality overall. There are potential barriers to healthcare facilities. There have been several studies looking at men's perspectives on accessing care and their concerns about confidentiality in these public sector facilities, access in terms of distance and inconvenient hours for people who are working, and the perceptions that these public sector facilities, these primary care clinics, are really geared toward maternal child care as opposed to being open to population designing services specifically for men. Additionally, most of the primary care clinics in South Africa are nurse-run and nurse-led, and more than 95% of nurses in this region are women. So you have women-led care for primarily maternal child health-oriented care. So there's a perception among men that's been demonstrated in several studies that primary care clinics are not for them or designed for them. There's a tremendous amount of stigma around HIV services in general, and feelings of compromised masculinity if people access care and services for HIV this way. The WHO and the United Nations have identified a number of key and vulnerable populations, and men and boys have now joined that list. Previously been somewhat neglected, but UNAIDS recently published a report called The Blind Spot, focusing on the fact that we've neglected efforts to focus on and target men and boys particularly for HIV. So there's some renewed focus in the last couple of years on men and boys, specifically for new initiatives in HIV care. We recently conducted a study that's currently under review a qualitative study amongst young men in our rural area, independent of testing efforts, who self-reported HIV negative status. These were largely young men who were unemployed with low levels of education. 52% had history of STIs, or sexually transmitted infections. We were surprised that 84% had actually previously tested for HIV, although not recently in the majority. 61% said that they were concerned about acquiring HIV. Overall, we identified from this population that HIV, being as prevalent as it is in this community and this region, is definitely on their minds. They're cognizant of their risk, but there's a lot of stigma and a lot of trust issues in relationships, as reported by these young men, that's not discussed. People don't feel comfortable discussing their risk and whether or not they've been tested when they're in their relationships. In this culture, in this local Zulu cultures, it is acceptable for men to have multiple partners and concurrently. You can be married with multiple wives, as well as maybe other non-married partners as well. And these can be serial, these can be concurrent. So there is a significant role of culture and cultural expectations that contributes to the challenges of HIV care here. So these are some representative quotes from our evaluation. And this polygamy is allowed to men, but not for women. Men can have as many women as he likes. It's our culture. It's our tradition. Men are responsible for building the nation. We are not equal. Men are the head of the household. Just to give you a sense of some of the common local beliefs that we have to work with as we offer and try to engage these populations for HIV testing and overall healthcare in general, and making sure that we're cognizant of these issues as we go forward. So where are the men? All the work that we've been doing is trying to engage community members where they are in the community. So we can't find them at the congregate settings. We can't find them at the households. So where are they? Most commonly, tribal or cultural events, which only happen a couple of times a year, at least in this traditional Zulu area. Sporting events, which are largely focused on the weekend, and the men are usually very actively engaged in that. And then alcohol venues. And having worked in this part of South Africa for the last 10 years, we've unfortunately experienced a rapid explosion of bars and taverns and the like. And so we discussed about approaching testing at these venues. So locally referred to as shebeens. They run the spectrum of being very informal, hole-in-the-wall places where people sit around a table, and but the primary activity is alcohol use and socializing, to more fancier or sophisticated venues where there's a pool table and a TV, and there might be a DJ and or a band playing on the weekend. So there's quite a spectrum of what shebeens look like in these areas. There's a lot of evidence, including for people here, showing increased risk of HIV acquisition under the influence of alcohol. Similarly, there's a lot of evidence demonstrating increased TB acquisition in people who use alcohol chronically. There's biological factors for that, alcohol suppressing part of the immune response and the ability to respond to an exposure to TB, but also the behavioral issues of drinking in congregate settings potentially that contribute to that. And also the co-infection with HIV that contributes to that increased risk. And certainly people who are engaged in excess alcohol are harder to engage in care. They have poor treatment initiation and treatment completion rates and adherence overall. Alcohol venues are oftentimes a very important part of the sociocultural scene, especially for young men and women, and that's especially true in our rural area. And it was mentioned that South Africa has a very high prevalence at this point of alcohol use disorders. Some recent data showing about 7%. That's much higher than countries in the region. We just recently completed a evaluation of targeting shebeens or alcohol venues in our area. We had an all-male community health worker team that we trained stationed outside the shebeens in our region in a mobile van. They offered health education and screening for communicable and non-communicable diseases I've described before. And it's important to note that we tried to engage people as they were walking in before they started drinking. We wanted to make sure people were not impaired so they could consent to HIV testing. So here, in comparison to congregate settings and households, the vast majority, 87% of the people that we tested were men in this setting, and the people that we identified that were positive. And you can see here also that we're identifying a younger crowd. So in the congregate settings, the mean age was 41, similar in the households, but we're definitely identifying a younger group here. So we screened about 1,300 people this way at the Shebeens, overwhelmingly men who were not employed, low levels of water, although this sample did have a lot of electricity. There was high levels of lack of condom use. 10% reported having sex with a known HIV-positive partner. 15% had reported a history of sexually transmitted infections. 40% smoked cigarettes. 15% marijuana. But 40% overall reported harmful levels of drinking, according to the WHO audit scale, which is a series of about 10 questions or so looking at alcohol use and dependence. And that's been validated across multiple settings. So for men, harmful drinking is defined as score greater than 8. For women, greater than 6. If you look at, for men, specifically 50% are reporting harmful levels of alcohol use in the setting. And then in terms of condom use, condomless sex, 34% say they always don't use condoms. And only 11% said that they always consistently use condoms. Overall, about 3/4 reporting inconsistent condom use. So this is just a flow of what we found. Overall, of 1,300 participants, 96% accepted testing for HIV. Only about 3% refused to test in this kind of environment. We found about 11% who were HIV positive. And interestingly, 65% said they knew their status. And some said that they were already engaged in care. Some smaller proportion that said they previously had been engaged and now had subsequently left HIV care and were no longer taking antiretroviral therapy. We identified a smaller number of people who were newly diagnosed, at least by self-report. Overall, we referred 50 people to care at public sector clinics. So overall, amongst those 50, we were able to link to care 76% of them. 95% we were able to get them, they obtained a CD4 count. Amongst all those who obtained a CD4 count, 100% of them started antiretroviral therapy. Now, which is great, very exciting, but given the scope of the project that we had, what we weren't able to determine was retention again. So we don't know the people that we were able to get into the system if they stayed in care, they stayed on antiretroviral therapy, did they experience viral load suppression? So that's what we're hoping to do next. And then similarly, we did, as I mentioned, we did integrated TB case finding as well. 229 reported at least one TB symptom. 43% we were able to get a sputum sample. 25% we were able to get into a clinic for a clinical evaluation, and we identified 5 TB cases overall, or 2%. So overall, the number needed to screen was 271. For people with an alcohol use disorder as defined by the audit scale, the number needed to screen was much lower, about 109. So there may be value to targeting people who are excessively drinking in order to do TB case finding. But as you can see, this wasn't 100% throughout. There's a lot of barriers to conducting this work in this kind of setting. Getting people to give us a sputum, for example, getting people into a clinical setting, getting people started on treatment. So, but I think there's promise there that we're hoping to go forward with. And I said we weren't going to be able to talk about TB preventive therapy, but I'll just mention that we also, as part of this effort, identified people who were living with HIV, but who did not have TB symptoms, and so therefore were eligible for TB preventive therapy. And we were able to identify that 46% were eligible. We referred the majority of those people, and 12% of those people initiated TB preventive therapy through this strategy. So again, community engagement for prevention. And again, we're hoping to build on this further and incorporate potentially HIV prevention as well. So we screened 71 people. We had barriers at each step, of course. I think we're almost out of time, but I'll just say that we did evaluate 480 community members who underwent testing at about 46 different shebeens. We looked at the characteristics associated with those shebeens to see if there's anything about particular shebeens that was indicated an increased risk. And we found that particular features that were associated with HIV positivity in this sample and had to do with location of the shebeens, shebeens that tended to be closer to town or in the center of town, shebeens that had bathrooms or private enclosed spaces where people could go for some privacy, and the fact that there were security guards, which may be a marker for kind of more sophisticated shebeens, seemed to be more associated with having identified people who were living with HIV in them. And then recently, we also just conducted an evaluation of social capital amongst people getting tested at shebeens, and looking at a sense of community amongst people frequenting the shebeens. And it seems that people who have stronger social connections in their community overall had lower HIV risk, and that's been well established in the literature. But in this setting, people who were drinking to excess, that increased hazardous alcohol use attenuated that protective benefit of social connections. So I think there's potential for interventions there to address alcohol use disorder and or to increase social connections in the community that would potentially ameliorate HIV risk. So overall, testing the shebeens yielding a high number and proportion of men and overall younger population engaging in high-risk behaviors. These kinds of community-based strategies may be adjunctively helpful to increase testing, awareness, and potentially improve individual treatment outcomes, particularly for men. So we're hoping to improve HIV services at the shebeens to test everybody, improve linkage to care for people living with HIV and be able to offer some sort of alcohol risk reduction interventions, incorporate HIV prevention for this population. So overall, I hope that I've showed you a little bit of data that demonstrates that community-based approaches are an effective way of improving case detection for tuberculosis and HIV, that we're able to identify people at a potentially earlier stage of disease, that we can use a variety of different targets in order to reach a variety of different demographic groups, that we are able to reach young men through these strategies, that shebeens are a potential high-yielding environment for HIV services, and that potentially we can also incorporate prevention services into these community-based efforts. There's a lot of people who have been involved in this work, both in South Africa as well as here in the US, and a number of different funders who have been in support of this work. Overall, I just want to say that, and again, these are pictures of some of these people, some of our team members in South Africa. Overall, say thank you very much for having me, and I'm happy to take any questions.
I think we have time for some questions.
Yes. First of all, thank you for a wonderful presentation.
Thank you.
Very much appreciate it. I had a few brief questions.
Okay.
Well, one wasn't a question, but I was impressed with how you integrated screening for tuberculosis and TB with what you were doing. I have questions. When you were in an earlier slide, you were comparing South Africa and the United States, and I'm wondering, in the United States, were people screened in prisons as well?
So we haven't done work in prisons in the US.
Okay, because I would think the rate would be higher than TB
Yes.
in particular.
Yes, it's definitely
Yeah.
considered a high-risk environment.
Trying to read my writing. Did you have mental health workers involved?
No. So thank you for bringing it up. That's something that we have not been able to focus on. We've looked at incorporating different scales, and we're hoping to incorporate that into our future screening efforts. I think we could spend a whole nother,
Sure.
talk talking about mental health care and the lack of services and the stigma associated with mental health in these kinds of settings. I think we've debated back and forth because mental health services are not widely available, so screening for something that we can't then refer somebody to is a bit of a concern. We're facing that with the alcohol too, though, so we're in discussions about how best to accomplish that.
And based upon how many people you screened at the Shavines, it seemed like, that was successful, because when most people go to a bar, they're not thinking of health education or getting
Right.
screened. That's impressive. And the last question is, do you speak the language of the native people of South Africa?
Oh, so this is a Zulu-speaking region. I've picked up a little bit of Zulu, but really just very basic.
So you always had a translator.
We always have
Thank you.
translators. Our staff are bilingual. Thank you.
What, I think I have this right, it was about half the people who presented with a symptom of TB screen for TB. Why would, I understand why people wouldn't want to test for HIV.
Right.
But why would someone not want to test for TB?
So I think the stuff that you're referring to is like 50% give us a sputum of those who have
I think so.
symptoms.
It was like 10 minutes ago. What was that?
Yeah, no, so there's constant challenges in terms of people who have symptoms but not able to give us a sputum on that spot on demand.
Oh, so it's like a physical?
So it's a logistical issue. People generally have a high yield of sputum, the sputum that we want at least, first thing in the morning. Laying prone or laying supine, secretions collect, and so early morning is the best time to collect sputum. During the course of the day when we're out in communities and people are out and about, it's certainly not ideal, but that's what we have. But still, it's sometimes hard to kind of just on demand cough up something when someone asks you to. So we have had that challenge. We've tried to institute sputum induction in the community, and that overall has not been successful for us. I know other groups who have had more success with that, and that involves basically nebulizing, saline, and trying to get enough moisture in the respiratory system for people to generate sputum on their own like that.
Are there emotional barriers to learning one's TB status?
Yeah, so that's the other part of it. There is a lot of stigma for TB, and we've tried to look at that issue. And some people will say that the stigma associated with TB is greater than with HIV, and I think it's a relative statement. There's been a lot more public health education in South Africa with regard to HIV, less so with TB. TB is associated with poverty. It's also associated with being HIV positive, so there's that issue. There's that overlapping issue. But TB, there's also a lot of misinformation about tuberculosis, it being a curse by the ancestors, or and afflicting people who are more disadvantaged or less well off. Again, that association with poverty. So TB has its own stigma and issues that's not being adequately addressed by public awareness and public health education campaigns. People know, the average person in KZN, I'd say, knows more about HIV or has more accurate information about HIV than they do about tuberculosis.
So, nice talk. The question I have has to do with linkage to care.
Yes.
With a community-based approach for testing for HIV.
Yes.
So, I'm wondering how that worked, because all the barriers that you laid out for engaging in care still exist, and getting tested in a care setting, you bypass that by going community-based and detecting cases. But I'm wondering what the experience is like getting people linked to care from community-based testing versus your experiences with the home-based testing, because that's much clearer to me. I know someone who's doing work, and you may know Susan Keene in Uganda. She just tested like 20,000 people doing home-based testing.
Right.
And it's a linkage to care study, so I understand how that works. And like with Pop Art, it was more community-based, right?
Right.
So, and Project Accept was like community-based, but they had like, but they had like a venue that they would pop up. So I guess I'm wondering, when you test in shebeens, what it's like to do linkage to care.
So that's a great question. We are linking people to their local HIV care facility, which for the most part is their local primary care clinic. We give people the option, if they, for some reason, don't want to go to their local primary care clinic or it's too far or whatnot, to go to the hospital-based HIV clinic, which maybe is in proximity, although people are technically supposed to go to their local primary care clinic first. We tried different methods, so it's not necessarily clean data on the linkage part. We tried just referring people. That generally has not been terribly successful. Facilitated linkage has been more successful, but obviously is more resource intensive. So escorting people, peer navigation, paying for transport money, we've tried different strategies to try to see what would be, to get some preliminary data to think about what we would want to try next. I'm trying to do a little bit more formal evaluation of this, but I think a large part of our shebeen success in terms of linkage to care was the fact that we were doing some peer navigation, but also I think a large part of it is, my speculation is that we had an all-male community health worker team that could very effectively engage with our male population at the shebeens. I think that peer demographic was very important to that. That's what I'm hearing anecdotally, but I need to do a more formal evaluation of it. So, again, we don't know the retention on that, so I'm wondering, I'm hoping we can look at that more formally. Yes?
Sorry, I'm ignorant of current assessments, but over 25 years ago when I worked at Miami University, faculty had to be screened for TB, and I recall it was a skin patch test?
Yes, in low incidence settings like the US, we would use a skin test, although these days we now have a blood test that we more commonly use. Because the skin test, you would have to plant it under the skin, you put the little liquid, and then you have to come back 48 hours later for a read, so it involves 2 visits. We have a blood test now that we use predominantly, it's one-time evaluation.
Thank you.
So that's for use in low incidence settings.
Right,
We don't
right.
use that, unfortunately, in high incidence settings like this. Any other questions?
I'm wondering, based on the data, I'm wondering if you're thinking about doing anything in the prisons. I mean, it seems like that's a really high probability of being able to get some work done. But I also know here, at least, there are barriers that you can't imagine when you try to go into, to do that kind of work.
Yes, so when we started, we were working in the prisons in terms of doing screening, and they were very open to us doing that, helping, because they didn't have a lot of support in the prisons. And there was 2 in our region that we were frequenting. Over the course of our time there, they have strengthened the health worker capacity at the prisons, and they're doing a much better job of HIV testing and ART initiation in the prisons. Not so much on the TB screening front in the prisons there, but because they now have a stronger healthcare worker presence in the prisons, we've kind of stepped back from that. But we'd love to kind of think about more.
All right. If anybody wants to stick around for a few minutes afterwards and talk to Dr. Shenoy, feel free. Thanks.
Thank you very much.